Welcome back to the Nurses Study Partner. This is Meningitis, Part 2, Complications, Special Pathogens, and Sequelae, in 10 in-depth scenarios. We'll cover meningococcal septic shock and DIC, raised intracranial pressure, SIADH, adjunctive steroids, hearing loss, and the special situations, listeria, TB and cryptococcal meningitis, neonatal disease, and encephalitis. Read each case, weigh all four options, pause to choose, then check your reasoning. Let's begin. Question 1. A teenager with meningococcal disease deteriorates rapidly, a spreading purpuric rash, very low blood pressure, cold mottled limbs, oozing from cannula sites, and clotting results suggesting DIC. Which severe complication is developing? Option A. A simple faint that will quickly self-correct alone. Option B. Mild dehydration needing only a little oral fluid. Option C. An allergic reaction to be treated with an antihistamine. Option D. Septic shock with DIC with Waterhouse-Friderichsen risk. Pause here and choose your answer. The answer is D. Septic shock with DIC and the risk of Waterhouse-Friderichsen syndrome. Rapid purpura, shock, and DIC in meningococcal disease is overwhelming septicemia, which can progress to Waterhouse-Friderichsen syndrome, bilateral adrenal hemorrhage causing adrenal failure. It needs aggressive resuscitation with fluids, vasopressors, and ICU care, IV antibiotics, treatment of the DIC, and often steroids for the adrenal failure. It is not a faint, mild dehydration, or an allergy. Question 2. A patient with meningitis becomes increasingly drowsy. Observations show a falling heart rate, a rising blood pressure with a widening pulse pressure, and irregular breathing. One pupil is becoming sluggish. What do these signs indicate, and what is the concern? Option A. Rising intracranial pressure, Cushing's triad. Act now. Option B. Simple anxiety. Reassure and recheck in the morning. Option C. Normal sleep. Allow him to rest without disturbance. Option D. Improving condition. No further monitoring is required. Pause here and choose your answer. The answer is A. Rising intracranial pressure, Cushing's triad, and you must act now. Bradycardia, hypertension with a widening pulse pressure, and irregular respirations are Cushing's triad, a late and ominous sign of raised intracranial pressure, here with a sluggish changing pupil suggesting impending herniation. This needs urgent action, senior and neuro review, head-up positioning, airway and oxygenation, measures to lower ICP such as osmotic therapy and imaging. It is not anxiety, sleep, or improvement. Question 3. A few days into treatment for meningitis, a patient's sodium falls significantly. He is not dehydrated and shows concentrated urine with a low serum osmolality consistent with SIADH. Which is the most appropriate initial management? Option A. Give large volumes of extra 4 fluids immediately. Option B. Ignore the low sodium. It needs no attention at all. Option C. Fluid restriction with careful sodium monitoring. Option D. Push high salt oral fluids and stop all monitoring. Pause here and choose your answer. The answer is C. Fluid restriction with careful sodium monitoring. Meningitis can cause SIADH, the syndrome of inappropriate ADH, giving hyponatremia with concentrated urine in a euvolemic patient. Initial management is usually fluid restriction with careful gradual correction and monitoring of sodium because correcting too fast is dangerous. Giving lots of fluid would worsen the hyponatremia, and ignoring it or stopping monitoring would be unsafe. Question 4. A patient with suspected bacterial meningitis is about to receive antibiotics. The team considers adjunctive dexamethasone. Which statement is most accurate? Option A. Steroids replace antibiotics and treat the infection. Option B. Dexamethasone reduces complications. Give it with or before antibiotics. Option C. Steroids should only ever be given weeks after recovery. Option D. Dexamethasone is used purely to bring down the fever. Pause here and choose your answer. The answer is B. Dexamethasone reduces complications and is given with or before the antibiotics. Adjunctive dexamethasone, given with or just before the first dose of antibiotics, reduces inflammatory complications of bacterial meningitis, notably hearing loss and other neurological sequelae, especially in pneumococcal disease. It is an adjunct, not a replacement for antibiotics, is given early rather than weeks later, and its role is not simply to lower the fever. Question 5. A child has recovered from bacterial meningitis. Before discharge, the nurse arranges follow-up, mindful of the most common long-term complication. Which follow-up is especially important? Option A. A routine dental check for a new filling only. Option B. An eye test purely for reading glasses alone. Option C. A skin patch test for common food allergies. Option D. A hearing or audiology assessment after recovery. Pause here and choose your answer. The answer is D. A hearing or audiology assessment after recovery. Sensorineural hearing loss is the most common long-term complication of bacterial meningitis from cochlear and nerve damage. So every child should have a hearing assessment after recovery, allowing early support such as hearing aids or, if profound, a cochlear implant referral. Other important sequelae include seizures, cognitive and learning problems, and hydrocephalus. A dental check, reading glasses, or a food allergy test are not the priority. Question 6. A neonate, an elderly diabetic, and a pregnant woman each develop bacterial meningitis. These groups are at particular risk of one organism that standard cephalosporins do not cover. Which organism and adjustments are required? Option A. Listeria. Add ampicillin or amoxicillin to the regimen. Option B. Only the common cold virus. No antibiotics are needed. Option C. A harmless skin germ. Simply reassure all three patients. Option D. A fungus best treated with a short antibiotic course. Pause here and choose your answer. The answer is A. Listeria. Add ampicillin or amoxicillin to the regimen. Listeria monocytogenes is an important cause of meningitis in neonates, older adults, pregnant women, and the immunocompromised, and it is not covered by standard cephalosporins like ceftriaxone or cefotaxime. So for these at-risk groups, ampicillin or amoxicillin is added to the empirical regimen. It is not a cold virus, a harmless skin germ, or a fungus. Question 7. A patient has a subacute illness over 2 weeks with headache, low fever, and cranial nerve palsies. CSF shows high lymphocytes, very high protein, and low glucose, and he is from a TB endemic area. Which diagnosis and treatment fits best? Option A. Acute viral meningitis, simple supportive care only. Option B. Classic acute meningococcal disease, single antibiotic. Option C. TB meningitis, prolonged anti-TB drugs plus steroids. Option D. A normal CSF result requiring no treatment at all. Pause here and choose your answer. The answer is C. TB meningitis, prolonged anti-TB drugs plus steroids. A subacute course, cranial nerve palsies, and CSF showing high lymphocytes, very high protein, and low glucose in a TB endemic setting fit tuberculous meningitis. Treatment is prolonged combination anti-TB therapy plus adjunctive corticosteroids, which reduce mortality and complications. This lymphocytic but low glucose picture is not typical viral meningitis, not acute meningococcal disease, and not normal. Question 8. A patient with advanced HIV and a low CD4 count has a gradual onset headache and fever. CSF microscopy with India ink shows encapsulated yeasts and the cryptococcal antigen test is positive. Which infection and treatments are indicated? Option A, bacterial meningitis, a short course of oral penicillin. Option B, cryptococcal meningitis, antifungals, amphotericin based. Option C, simple migraine, treat with painkillers and reassurance. Option D, viral meningitis, no specific treatment is ever needed. Pause here and choose your answer. The answer is B, cryptococcal meningitis, treated with amphotericin-based antifungals. Encapsulated yeasts on India ink and a positive cryptococcal antigen test in an HIV or immunocompromised patient indicates cryptococcal meningitis from Cryptococcus neoformans. Treatment is antifungal therapy, typically amphotericin B with flucytosine for induction, then fluconazole, plus managing raised intracranial pressure with therapeutic lumbar punctures. It is not bacterial migraine or ordinary viral meningitis. Question 9. A 10-day-old baby is unwell with fever, poor feeding, lethargy, and a bulging fontanelle. The team plans empirical antibiotics, mindful that neonatal meningitis is caused by different organisms than in older children. Which organisms and approach are correct? Option A, Group B strep, E. coli, Listeria, neonatal antibiotics. Option B, only meningococcus, use the standard adult regimen. Option C, no bacteria are ever involved in newborn meningitis. Option D, a fungus only, treat with a single antifungal tablet. Pause here and choose your answer. The answer is A, Group B strep, E. coli, and Listeria, treated with a neonatal antibiotic regimen. Neonatal meningitis is typically caused by Group B streptococcus, E. coli, and Listeria, acquired around birth. Empirical treatment uses a neonatal regimen, commonly ampicillin plus cefotaxime, or an aminoglycoside such as gentamicin, to cover these organisms, differing from older children and adults. It is not only meningococcus, not free of bacteria, and not a single antifungal tablet. Question 10. A patient has fever with confusion, personality change, and seizures. Unlike typical meningitis, the picture is dominated by altered brain function and herpes simplex encephalitis is suspected. Which distinction and treatment are correct? Option A, it is identical to meningitis, only gives simple antacids. Option B, encephalitis affects brain tissue, ignore and observe only. Option C, encephalitis is brain inflammation, start IV acyclovir. Option D, it is purely psychiatric, no medical treatment is needed. Pause here and choose your answer. The answer is C. Encephalitis is brain inflammation and you start IV acyclovir. Meningitis inflames the meninges, so meningism dominates, whereas encephalitis inflames the brain tissue itself, so altered mental function, personality change, and seizures predominate. Herpes simplex encephalitis is a key treatable cause, and IV acyclovir must be started promptly, early, even before confirmation, because delay worsens the outcome. It is neither identical to meningitis, safe to ignore, nor purely psychiatric. Let's recap meningitis part 2. Meningococcal sepsis brings purpura, shock, and DIC, and can cause Waterhouse-Friderichsen syndrome from adrenal hemorrhage. Cushing's triad, bradycardia, hypertension with a widening pulse pressure, and irregular breathing, signals raised intracranial pressure. Act fast. SIADH causes hyponatremia, managed with fluid restriction. Adjunctive dexamethasone, given with or before antibiotics, reduces complications like hearing loss, which is the commonest sequela, so arrange audiology. Add ampicillin to cover listeria in neonates, the elderly, pregnant, and immunocompromised. TB meningitis is subacute with lymphocytic, low glucose CSF, needing anti-TB drugs and steroids. Cryptococcal meningitis in HIV shows India ink yeasts and a positive CRAG, needing antifungals. Neonatal meningitis is group B strep, E. coli, and listeria. And encephalitis inflames the brain tissue. For herpes simplex, start IV acyclovir early. Keep going, and remember, we don't pass alone, we pass together.